Welcome back, clinical problem solvers. It's Rabih and Reza. This story is a story of a young woman with 4 months of daily high spiking fevers. She's been evaluated across multiple hospitals and continents. Infectious, malignant, and autoimmune workups were unrevealing. Imaging was negative. Cultures were negative. Over time, key clues faded, not because the disease changed, but because its most specific features were transient. A rash that appeared briefly early on, a sore throat that resolved. What remained were fevers. This case matters because it shows how fleeting features in time itself can obscure a unifying diagnosis hiding in plain sight. By the end of this video, we want you to be able to recognize when Still's disease belongs on your differential for fever of unknown origin, understand why the diagnosis is so often delayed, and know the specific clinical and laboratory clues that help separate Still's from infection, malignancy, and autoimmune disorders. Let's walk through the reasoning. When fever persists for weeks to months, atypical infections, liquid cancers, and autoimmune diseases are the right starting points. But the longer the fever continues without organ destruction, focal findings, or imaging abnormalities, the more we should ask whether the immune system itself is the problem rather than a hidden pathogen or tumor. Still's disease is autoinflammatory, not antibody or antigen mediated like autoimmune diseases. It's driven by the innate immune system. This distinction explains several things. ANA and RF are usually negative. The white count is often neutrophil-predominant because of the innate immune system and can closely mimic bacterial sepsis. And the syndrome feels inflammatory but non-specific. The classic teaching describes a pentad: fever, arthritis, rash, pharyngitis, and reticuloendothelial activation. But the pentad is a teaching tool, not a diagnostic rule. The trap is that these features rarely appear together. The fever is a major clue and often an early manifestation. It's high spiking, often above 39 degrees Celsius or 102 degrees Fahrenheit. It occurs daily or twice daily, and it's usually brief. Arthralgia or arthritis occurs in most patients. The wrist, the knees, and ankles are common sites. It may start mild and evolve into a symmetric, destructive polyarthritis. The rash is evanescent. What the heck does evanescent mean? It means short-lived. It comes and goes, often appearing only during fever spikes. It's classically salmon-colored, macular or macular-papular, and usually non-pruritic. It might demonstrate Koebner's phenomenon, where new lesions appear at sites of skin trauma, such as pressure or scratching. Importantly, these new lesions replicate the appearance of the original rash rather than forming a new morphology. Pharyngitis occurs in about 70% of patients. It's often prominent early in the illness and then forgotten by the time the dominant inflammatory syndrome emerges. You see, these symptoms can be very scattered, making it very difficult to diagnose Still's disease. Now let's talk labs. ESR and CRP are elevated but nonspecific. The white count is typically high with neutrophil predominance, the innate immune system. Bands may be present, creating a left shift that closely mimics sepsis. This reflects innate immune activation, not infection. Ferritin is often markedly elevated. In Still's disease, ferritin production from the liver, from the macrophages, becomes so excessive that the glycosylation machinery is overwhelmed. We glycosylate ferritin to stabilize it. As a result, the proportion of glycosylated ferritin is low, often less than 20% of the total ferritin value. This can be diagnostically helpful. However, most labs in the US can't routinely distinguish glycosylated from non-glycosylated ferritin, limiting its real-world availability. LDH is frequently elevated, reflecting cytokine-driven tissue injury, particularly involving the liver and bone marrow, where inflammatory turnover of cells is high. Now, the critical complication, macrophage activation syndrome, is uncommon but deadly. and it's the leading cause of mortality in adults with Still's disease. MAS is a form of secondary hemophagocytic lymphohistiocytosis that occurs in the setting of systemic rheumatic diseases in which macrophages and cytotoxic immune pathways are pathologically overactivated. The immune system is stuck in the on position. Here's the pearl. In a patient with Still's disease, leukopenia or paradoxically low or falling ESR should make you worry about macrophage activating syndrome. Leukopenia occurs because activated macrophages consume blood cells and suppress marrow function. ESR, erythrocyte sedimentation rate, may paradoxically fall despite inflammation, sometimes earlier than other inflammatory markers because the fibrinogen drops due to the liver dysfunction in MAS. Fibrinogen causes red blood cells to stack into RULU by neutralizing their repulsive forces. When fibrinogen is low, red cells repel each other. They sediment more slowly and the ESR falls. This occurs in the setting of liver dysfunction and consumptive inflammation, even while CRP, which reflects interleukin-6 driven hepatic synthesis and does not depend on fibrinogen. And remember, IL-6 and IL-1 are huge players in this autoinflammatory disorder, and liver enzymes remain stable or rise. That disconnect of ESR dropping or the white cell falling in someone with Still's should alarm you. So when should you suspect Still's? Any fever of unknown origin in a young adult. The mean age is in the 20s to 40s. Men and women are affected equally. The disease is exceedingly rare in older adults. And duration matters. Many mimics of Still's resolve within 2 weeks, while Still's persists. The diagnosis is clinical. Sensitive features include the high spiking fever, arthritis, and pharyngitis. More specific clues include a transient rash, leukocytosis with neutrophil-predominant, a high neutrophil to lymphocyte ratio, a marker of innate immune dominance, and markedly elevated ferritin with a low glycosylated fraction when available. As you imagine, the differential diagnosis remains broad. Acute viral infections, systemic autoimmune diseases, lymphoma, and HLH all must be considered. MIS-A, multi-system inflammatory syndrome in adults, is another important mimic. It's a post-infectious hyperinflammatory syndrome associated with prior SARS-CoV-2 infection and can closely resemble Still's early on. Treatment reinforces the diagnosis. NSAIDs help patients with mild disease, and the response can be dramatic and sometimes diagnostically informative. Steroids are first-line therapy for most patients. Methotrexate is the preferred conventional DMARD, disease-modifying anti-rheumatic drug, and biologics targeting the underlying cytokines, IL-1, IL-6, such as anakinra, which is an IL-1 receptor antagonist, have really transformed outcome in patients with Still's. JAK inhibitors are emerging as options in refractory disease. Let's close with the take-home points. And my partner is very happy to hear those words. As we are cooking in this dark room and the beautiful tortilla soup is just boiling. I didn't pronounce it, I did tortilla soup. Still's disease is delayed because its inflammation is nonspecific and its hallmark features are fleeting. Always ask about the beginning of the illness.
That's a wrap, folks.